Hello, this is Sasank Med. This is a lecture on acid-base disorders. So this lecture is kind of like the bare bones you need to diagnose and treat acid-base disorders. Just a high-level overview so that you can dive into it deeper with greater understanding. So let's jump right into it. So, as we know, your blood has a certain pH level, and your body's regulatory mechanisms are working to regulate the pH through acids, bases, buffers, and respiratory and kidney function. The normal range is 7.37 to 7.42. Anything below that range is acidic, anything higher is basic. So lungs adjust pH by expiring CO2. Kidneys adjust pH by absorbing or excreting acids and bicarbonate. So the other data points to know is the values listed in arterial blood gas measurements. So normal bicarbonate is between 22 to 26, and partial pressure of CO2 is between 35 and 45. Okay, so the Henderson-Hasselbalch equation helps outline the function of lungs and kidneys affecting pH. So the equation is 6.1 plus log bicarbonate over zero point zero 0.03 times partial pressure of PCO2, or partial pressure of CO2. So the numerator is bicarbonate. So if it increases, the pH goes up. The denominator is like carbon dioxide. So if it goes up, the pH decreases. Um, so your lungs breathe in out, so you inspire oxygen and expire CO2. So this equation here is called the bicarbonate buffer in the blood. And basically it's H plus ions plus bicarbonate is equal to carbonic acid. And that could transform into CO2 and H2O. So this is an equilibrium reaction, so it can go both ways. So if you expire more CO2, more hydrogen ions are converted into the leftward reaction, and your body becomes more basic. So your blood becomes more basic. So this conversion takes place in red blood cells, and the lungs can compensate relatively quickly and changes to blood pH. The kidney has many excretory, secretory, and absorbing mechanisms, but long story short, it can reabsorb and excrete bicarbonate or acid to change serum pH. It takes longer to compensate, so it takes a while for the compensation to kick in. So it compensates using hormonal and sympathetic innervation. The kidneys can react to pH changes and maintain homeostasis. So if the pH is basic, the kidneys will excrete more bicarbonate and absorb more acid, and vice versa. So this is a simple flow chart to figure out what acid-base disorder it is and the primary mechanism of compensation. So if the primary disturbance is CO2, then it's respiratory. If the primary disturbance is bicarbonate, then it's metabolic. So what causes respiratory acidosis? So simply put, it's anything that makes the lungs breathe less. So we will review the causes. So um, like let's see if this works. So, inhibition of the medullary respiratory center. It's opiates, barbiturates, anesthetics, lesions of the central nervous system, central sleep apnea, oxygen therapy, disorders of respiratory muscles. So, Guillain-Barré syndrome, polio, amyotrophic lateral sclerosis, and multiple sclerosis. Airway obstruction is aspiration, obstructive sleep apnea, laryngospasm, and disorders of gas exchange, like acute respiratory distress syndrome, chronic obstructive pulmonary disease, pneumonia, pulmonary edema. So, causes of respiratory alkalosis is anything that makes the lungs breathe more. Simply put, so we will review the causes. So, stimulation of the medullary respiratory center is hysterical hyperventilation, gram-negative septicemia, salicylate poisoning, neurological disorders such as tumor, stroke. So hypoxemia is another cause, caused by high altitude, pneumonia, pulmonary embolism, severe anemia. Then we have mechanical ventilation, and so that's its own thing. But so for respiratory disorders, you first have to see if there, well, after you've realized that it's respiratory uh, acid-base disorder, you then have to see if the change in CO2 corresponds to the change in bicarbonate. So if there's an increase in 10 millimeters mercury of PaCO2, or sorry, increase in 10 millimeters mercury of PCO2, then bicarbonate should go up either 1 or 3.5 milliequivalents per liter in either acute or chronic respiratory acidosis, respectively. So if there's a decrease in 10 millimeters mercury of PaCO2, then bicarbonate should decrease by either 2 or 5 milliequivalents per liter in either acute or chronic respiratory alkalosis, respectively. So if it's more or less than that, then it's a mixed base disorder in which the kidney is also compensating. What's the treatment of respiratory acid-base disorders? So you treat the primary cause. So if it's not sufficient, consider mechanical ventilation. So then you decide if you want to use non-invasive or invasive ventilation. So in order to do that, you can first determine if the mental status is non-responsive or alert. If non-responsive, you can use invasive ventilation such as endotracheal or mechanical ventilation. If the mental status is alert or altered, you can use non-invasive such as BiPAP and CPAP. There are common modes on these. So the most popular mode, the most commonly indicated use is pressure support ventilation, in which is the most common choice, where patients dictate the respiratory rate and the machine adjusts accordingly. So metabolic acidosis, this one's actually like the trickiest, but basically, it's a decrease in the serum pH due to addition of acid or loss of base. So there's decreased bicarbonate. So the first thing you do is calculate Winter's formula, which is 1.5 times bicarbonate plus 8 plus or minus 2. So if PCO2 is not in that range, then this is a mixed acid-base disorder, and there's concomitant respiratory compensation. So the next thing you do is calculate anion gap. So anion gap is sodium minus chloride plus bicarbonate. The normal is 8 to 12. Um, if it's higher than that, then it's HAGMA, or high anion gap metabolic acidosis. If it's normal, then it's normal anion gap metabolic acidosis, or NAGMA. So what is anion gap? This is basically like so this is a diagram, is a picture of your plasma. So the anion gap is basically first of all, you have cations and you have anions. So the cations are the positively charged ions, which is usually sodium, and then you have negatively charged ions, which are the anions. And so you have bicarbonate, you have chloride, and then anion gap, which is basically your unmeasured anions. So it's acids that are not included in standard labs. So Hagma is an increase of this anion gap or unmeasured acids, and Nagma is a loss of bicarbonate with compensatory increase in chloride. So then you have to memorize the acronyms. So for Hagma, the one I like is mud piles. So M methanol, U uremia, D diabetic ketoacidosis, P paraldehyde, I iron and isoniazid, L lactic acidosis, E ethanol, ethylene glycol, and S for salicylates. And NAGMA is Durham, so diarrhea, ureteral diversion or fistula, renal tubular acidosis, hyperalimentation, acetazolamide, Addison's disease or adrenal insufficiency, and then miscellaneous. So what's the treatment? So you give sodium bicarbonate, and then do you give IV or oral? So if it's acute, then IV sodium bicarbonate. If you need to titrate slowly, then oral is uh, chosen. So metabolic alkalosis, so that's a little bit more simple. So it's an increase in pH either due to addition of base, such as reabsorption of bicarbonate or loss of acids in the blood. But there are two types of metabolic alkalosis, so either saline responsive or saline resistant. And basically, if the metabolic alkalosis is due to some loss of body fluid, such as urine or like gastric contents, then it's likely saline responsive. If it's due to kidney dysfunction, it's likely saline resistant. So you review the causes. So like basically, saline responsive is like vomiting, thiazide or loop diuretic use, volume depletion, post hypercapnic alkalosis. Urine chloride, so saline resistant is same thing. Recent thiazide or loop diuretic use, hyperaldosteronism, Bartter syndrome, Gittleman syndrome, Little syndrome, which are all disorders of the kidney. So what's the treatment? So if you have metabolic alkalosis, if it's saline responsive, you can use isotonic saline to increase the bicarbonate excretion and correct the fluid loss. If it's saline resistant, you need to treat the cause of the hydrogen ion loss. So if it's adrenal pituitary tumors, removing them. You can also use spironolactone or eplerenone and amiloride.